So we talked a lot about approved therapies, but there are also some, let's say, experimental strategies, cell-based strategies like stem cell therapies or CAR T-cell therapies. And I mean, it's very clear that not a lot of patients are qualifying for cell-based therapies, but at least I think it's a valuable option in specific situations. And this is why I would like to ask you to introduce and also maybe discuss the MOA concerning stem cell therapies and also CAR T-cell therapies.
Yeah, so they're not too dissimilar in some aspects of how they're given. So both involve chemotherapy. For both, you'll need to be in hospital for a few weeks probably. But they are different in significant regards. So let's just go for the stem cell therapy as the first therapy we'll talk about. It's quite important to me as a practicing clinician who sees a lot of patients who want to have a stem cell therapy to clearly say that although we are giving you your stem cells again, so we'll give you a hard chemo that makes your immune system basically down to zero, and we give you your own stem cells back again to rebuild your immune system. It's not like we're giving stem cells that then go into the brain and act like regenerative stem cells that you might have heard in the media that then heal the scars of MS, and then you can stand up from a wheelchair or you can move the hand that you've not been able to move for 5 years. That's not the goal of these stem cell therapies, and that's not something you can realistically expect to happen from these therapies. It's not anything to do with healing things that have already been damaged by the MS. Rather, it's trying to stop the MS in its tracks. So that's an important misconception, I think, that some patients have, that we say, the stem cell therapy isn't right for you, and then they think, well, I want to be healed, and why not? That's not the case. It's a very highly effective treatment for patients who have failed the other therapies with risks that are relevant, and in Germany it's a 1 in 100 mortality that needs to be taken seriously and considered very deeply by the patient and by the caregiver or by the healthcare professional. So what happens when you want to have a stem cell therapy? So the first thing we have to do is select the patients very well. So usually younger patients, and like the guidelines suggest, patients with a relapsing remitting MS form tend to have better outcomes. And these patients then, first of all, will be checked over. So heart, lungs, blood, are there infections like hepatitis, HIV, that would then, when we completely turn down the immune system to zero, are going to come up and bloom and cause a fulminant liver inflammation. We don't want to have that happening. So a lot of pre-checks are involved. A really important part of the pre-check is also fertility. So women and men can both become infertile due to this highly effective and intense chemotherapy, and that's something we need to discuss in advance, whether we need to freeze away sperm or eggs for those patients in the future. So a lot of preparing is necessary. And then we can do this as an outpatient, as we give a therapy that releases the stem cells from the bone marrow, and we collect them and freeze them away. And it takes a few days to collect enough stem cells, and when we have enough and they're frozen away, we can admit the patients for the chemotherapy. In Germany, we give cyclophosphamide. In Italy, they give a different regimen, but generally cyclophosphamide is one of the 2 recommended regimens that you give for the reduction of bone marrow and the reduction of the immune system to zero. So we basically destroy that immune system. So basically, we destroy the immune system so that we can rebuild it. That is in a different, so that it's not as prone to attacking the nerve and the spinal cord as it is in the MS patient before the stem cell transplantation. And you come into hospital, the therapy will be given, you'll be isolated, you'll have a mask on, and you'll have to protect yourself from viruses and illnesses. And that would be for many weeks, this phase where your immune system's destroyed, or so good as basically destroyed, and then you're given your stem cells that have been frozen away. They're given back into your bloodstream, and they can then take hold in your bone marrow again and build up a new immune system. And that's the stem cell therapy. So it takes up to a few weeks in hospital, and it's a very aggressive chemotherapy, and you're in a very vulnerable state when your immune system is it's been so reduced to zero as it is in the case of this therapy.
If I may interrupt, I mean, stem cell therapies are discussed since the 1980s, in my opinion. Maybe patient selection was a problem back in these days. However, if we compare numbers of stem cell transplanted MS patients in Germany, for instance, with UK, there is a huge difference. So the procedure is more often offered, obviously, in the UK compared to Germany.
Yeah.
Do you know the reason behind?
So the UK is very much a guideline-based practice system. So Germany is a bit more kind of based on what those doctors are deciding in that moment, and the UK is a lot more, what does the guideline say specifically for this patient? And the UK is also more of has to be more of a cost-based system because it's a public healthcare system. And if you think about a stem cell treatment, it's maybe 40,000 euros. And these B-cell depleting therapies like ocrelizumab, ofatumumab, they are then in over 10, 20 years, obviously a lot more expensive than having the stem cell treatment once. And both of these things are then taken into account in the UK. Well, here's a guideline, it says quite clearly at this stage we can offer the treatment, and then you do it without thinking, oh gosh, that's pretty hardcore, and is that the right thing? It's there in a clear guideline, and that's definitely coming in Germany, and we have the new guidelines that say that you can decide to do this treatment in patients, but it's more clearly stated in the UK. I would say that it's an option at that stage.
Okay. And if you now compare stem cell therapies with CAR T-cell approaches, where's the big difference? I mean, you talked already, there are some similarities, but where are the differences? Yeah,
so chimeric antigen receptor T-cells, so basically in these patients we also take away cells. We would then extract T-cells from the blood, we genetically modify them or change the nature of the T-cells so that it's primed to attack B-cells in the body. Kind of like ocrelizumab, but in cell form. And then we take the patient into hospital, we also give them cyclophosphamide, we reduce the strength of their immune system again down to a very low point so that when we give these T cells into the blood, they can also attach themselves and grow well in the bone marrow and become a part of the new immune system. And these T cells are then able to really deeply deplete B cells in the actual tissue. So the antibody therapies like ocrelizumab, ofatumumab, they're in the blood and they can attack and destroy B cells in the blood, but they can't really get into the tissue. T cells that are designed to destroy B cells can get into the tissue. So you can argue that this deeper level of B cell depletion would cause a more effective treatment and more effective B cell depletion than the antibody therapies if the antibody therapies weren't enough for the patient.
But I learned in my career, if there is a higher effective treatment, there are sometimes also more significant side effects.
Yeah.
Are there side effects with the CAR T-cell therapy?
Yeah, it's a new therapy in autoimmune disease, but we know it since about 2016 for hematological malignancies. I mean, just giving such a aggressive chemotherapy is associated with side effects. When it's to cure cancer, then you say, who cares about the side effects? This is important. We need to get rid of this cancer in this patient. But in MS, it's not quite as easy to choose between a treatment that could potentially be fatal for that patient and to say, I know I'm doing the right thing by giving such a strong chemotherapy. And the T cells don't always take a good hold in the body, and you don't always get a very good response. And in some cases, we even have these T cells then forming a malignancy themselves in the blood. Very rare, very rarely reported, but a possibility. And we don't have 10, 20-year follow-up data for this CAR T cell therapy. So bit of a question mark there. So as far as we know, it's a good treatment that doesn't have ridiculously severe side effects. However, it's definitely a step up in the side effects compared to the highly effective platform 3 or step 3 therapies.
There are also some side effects described due to the immunology the nature of the immunology of the treatment, so like cytokine release syndromes or ICANS. Can you maybe define this shortly?
Yeah, so when the B cells are all destroyed at once in the body, you get kind of like a cytokine response like you do when you have the flu. And that cytokine release syndrome, that's kind of this whole body destruction of B cells, causes then you to have fever and joint muscle pain like you would if you had a flu. And this cytokine storm can also take place then in a way in the brain, and that can be quite serious, causing brain swelling and causing seizures, and that would be then a severe complication of CAR T-cell therapy, and that would be then ICANS. I would, however, say that in the context of autoimmune disease, so when you have a malignancy, a lot of B cells are destroyed at once because they are cancerous and they're produced in huge amounts. But in the normal immune system, then you have fewer, and the response would be then less severe in terms of these cytokine storms.
Thank you.